So you might know medical jargon, but let's interpret medical slang. Bucking the vent. This is when a patient is asynchronous with the ventilator and either needs changes in ventilation settings or sedation. BIBA. I've only seen this in California, but the first time I saw it and I asked what it was, the nurse looked at me like I was an idiot. It essentially means brought in by ambulance. Next one I learned the hard way as a new grad. Do not stand in the line of fire. When you are cleaning a trach patient's site, you do not want to stand anywhere near where they could cough and the loogie could come flying out and land on you. And let me tell you, at any point which way they turn, do not stand in front of that, okay? Don't stand in the line of fire. A brittle diabetic is a diabetic that you need to be extra careful in monitoring when you give them even small amounts of insulin, because even a couple units of insulin could make this patient drop significantly. So you need to be monitoring this patient a little more closely. This next one is just a phrase that helped me remember to sedate my patient before I paralyze my patient, and it is date before you suck. Meaning sedate your patient with etomidate before you paralyze your patient with succinylcholine. A patient that is circling the drain is typically a critically ill patient that is nearing their end of life. Do you guys have any slang terms or phrases you've learned within healthcare? Please put them in the comments, because I think that this helps new grads and new residents a lot more than not. If you've never worked in healthcare, you probably have never heard some of these things, so let's help each other out. Oh, this better be a joke. This is Olivia. Hey, this is Lab. Who sent this sample down here?
Yeah, the one that just came in.
1 second. Let me get my preceptor.
Oh yeah, let me
Talk to that nurse. Let me talk to that nurse. Hey Jordan, I sent a C. diff sample down to Lab, but they're yelling at me on the phone and I don't know what to say. Will you talk to yelling at you? Give me the phone. This is Jordan, her preceptor.
Hey, Jordan.
This is Lab. I'm just curious who sent this solid turd down here.
Lab.
Solid?
It literally looks like corn on the cob.
Type 2, type 3.
It's got a little bit of form.
Olivia, did you send a
there's no
solid
smell.
turd?
I would be able to smell this just from the bag itself. Of course it's not seeded.
Yeah,
Literally looks like corn on
okay,
the
thanks,
cob.
noted.
I
I can't even explain it to you. Hello? So, a couple things. Have you ever seen C. diff? Okay, actually come with me to bed 3 because I'll show you what it actually smells like and looks like. Seriously? Who are you? Oh, hey, I'm from the ER. They floated me here. ER? They sent me somewhere from, oh my God. Never been here before. It's kind of cold. Well, your hair's still wet from the shower you took this morning. You didn't bring a jacket or a vest or no long sleeves, did you? You got some deodorant on your shirt though. At least you know I have it on. All right, well here's your 2 patients. Go get report, please. Thanks. 2 patients? Hey, Vicky. Hey, could you help me program this pump? It won't stop beeping. You don't know how to program a pump? We usually just use gravity. What's the patient's urine output? I don't know. They peed. Why? You need a urine sample? You think they're pregnant? Drugs? UTI? What charting? What? I feel like I already did it all. Ugh, which one means stop? God, they're all beeping. How do you get this to stop? Wait, you guys actually titrate this shit? Hey, can you help me with a boost and a turn? Turn them where they don't even move. That is precisely the point of turning them. We gotta check their skin too, come on. Oh, the skin they have, they've got it. They've got skin. Don't forget to do their oral care, okay? Every 4. Oral care? Oh, I'm gonna vomit. And literally nothing makes me vomit. What the You guys don't get bored up here? I'm a little bored. Anytime I'm not in the room, I'm a little bored. If you're anything like me, as a new grad, ventilators scared the shit out of me, and I learned very early on that the RT was going to be one of my best friends in the hospital. So I'm gonna give you a few tips and tricks that they taught me that helped me not be so afraid of the ventilator. If you hear this sound, that is a high peak pressure alarm from a ventilator, essentially saying, I am not breathing, or get your ass in here. And if you get confused on what to do with a high pressure or low pressure alarm, an RT taught me hold, high, obstruction, low, disconnection. Since we know this is a high pressure alarm, it means high obstruction. There's most likely an obstruction within the tubing or something within the patient that is not getting airflow to the lungs. This is when you're going to be checking the tubing for kinks, the patient for biting or heavy secretions, and an acronym an RT taught me was BLOCK, which stands for biting from the patient, liquid in the tube, an obstruction, copious secretions, or a kink in the tubing. And if you can't quickly troubleshoot what's going on with the ventilator, the best thing to do is always call your RT. Who are you? You're here to help us? Oh, hi. What are you, from the ICU? I am actually. How'd you know that? Listen, if I were you, I'd take that vest off so you can blend in a little more. Look like a fucking narc. I like my vest. Hey, where can I find a straight calf? Did you check the supply closet? Okay, check the supply closet. We've got 2. What if I already checked there? I don't know what to tell you if you can't find one. Look in the drawers or something. Drawers? What the fuck? Who left a Kindle here? Texas Roadhouse. What are you doing? We got a trauma coming in. You're trying to label some lines? That's so ICU coded. Hey, could maybe you help me with an IV next door? You can't place an IV? I'm an ICU nurse. We don't do those often. Okay, that's actually fair. Why is everyone screaming? Every time I show you guys a video of my report sheet, you get caught up on the lab section because a lot of us start by writing our labs out in a line. And while that's fine, if that flows for you, I prefer using fishbones because it keeps my labs very organized and I know exactly what I'm looking at whenever I see this. Let me explain. When I was a new grad, I used to write my labs down in a row, but as I gained more experience, I started preferring these fishbone methods, and let me teach you why. This represents your BMP, or your basic metabolic panel. And what goes in each of these is what you can expect to find when your doctor orders a BMP. This is your sodium, your potassium, chloride, bicarb, BUN, don't say bun, creatinine, glucose. This one represents your CBC, or your complete blood count. You have your hemoglobin, hematocrit, white blood cells, and your platelets. This represents your liver panel, total bilirubin, AST, ALP, ALTs. This represents your renal diagram, calcium, magnesium, your phosphorus. This one represents coagulation, or your coags, PT, INR, and your PTT. At first, this was really hard for me to learn, but I was determined to use fishbones instead of writing out each lab one at a time. So I would Google this every single shift, and I would literally write this out on my report sheet somewhere so that I would eventually memorize it. Now, every shift, it doesn't mean I'm going to be writing all of these down, but depending on what's happening with my patient, if they have a GI bleed, I'm gonna wanna know their CBC and any changes that they've had in it. If they've had a lot of sodium issues or potassium issues or anything that involves a BMP, I'm gonna wanna have that written down as well. If they're on a heparin drip, I'm gonna wanna know what my coags are looking like and any trends that I have within these labs. So I like to have these written down on my report sheet somewhere. Something else I like to do with patient labs to remember the ranges was put arrows next to things that were abnormal. For instance, this is a low sodium, so I would put 1 arrow next to it. However, if they were critical, I would do something like putting 2 arrows going up. That means they're hyperkalemic, and this is a critical value. We're a little low over here, so I put an arrow there, and everywhere else looks normal.
No, unfortunately, even if it is a bloody stool, we can't draw blood from this for a CBC. It has to be from a vein.
Hey, so you said an empty tube. Was there supposed to be something in this, or?
Please pick up the phone.
Yeah, I'm so sorry. You guys are gonna have to recollect that. It hemolyzed.
Oh, you're short-staffed?
So are we.
Was it a stat? So you guys sent down labs, but there's no order for these labs?
It just came through? Okay.
Oh, you have a 4-year degree?
So do I.
Who the fuck put urine in the tube station again?
So you're gonna have to walk that specimen down here because one of your other nurses put urine in the tube station and it's down again. Just a reminder, when you guys label these tubes, I need initials, date, aura points, and the flavor of popsicle that the patient likes the most written down on here. And make sure you don't cover up the window so we can see how much volume is in it.
Hey, so I think you guys are yanking the syringe like a lawnmower whenever you're trying to draw blood, and it's causing hemolyzation.
No, that actually doesn't happen down here. It happens with you guys, actually.
Just pick up the fucking phone. Jules from lab. When did you send it down? 2 hours ago? Okay, so just because you sent it down 2 hours ago doesn't mean we started testing 2 hours ago, because there's like 1,500 million patients in this hospital. So it's somewhere down the line. Oh, was it a stat order? Oh, it wasn't? Okay, so it's somewhere down the line.